variables around this thing is really who should own the information. It's the patient who should have access to it. It's whoever the practice or the patient deems is worthy of having it.
We've got some time to take some questions from the audience as we look at the time left. We will let our keynote have the first question.
I have a quick question regarding meaningful use. I really think that if this is going to be widely adopted, in the healthcare arena, and the Healthcare Reform Act requires physicians to start using it with a bonus up front and then later to be penalized for not using it, how are you all adopting meaningful use in your respective organizations?
Sure. I can start first. We have a subsidiary called Ingenix that actually went out and built an easy-to-install electronic medical record that's web-enabled. It's called Care Tracker. That has been demonstrated and has been certified to allow people to achieve meaningful use. It costs about $7,000 a year. Physicians are being provided with an incentive if they show meaningful use, and they should be able to enjoy that. So there's a financial incentive, but the obligation we have to the physician is two things. Number one, make it easy to use, and then as Martin was saying, something very important, make it easy so that the doc doesn't have to be loading the information. Given that we're getting all this information about their patients, to load it in for them so that it's worthwhile to go to.
So I would just follow up and say, I think there are really two things. The financial incentive is one thing, but I don't believe that will drive adoption. It has, meaningful use to me is a base, and just so everyone understands, the federal government is investing close to $30 billion to drive the adoption of EMRs in this country. So there are 800,000 physicians in the country. There's probably less than 100,000 that are using an EMR today, and certainly not effectively. So going forward, that investment is designed to incent people to adopt it. But what I will tell you is if we set the bar at just meeting meaningful use, we're going to miss the greater value in getting physicians onto an EMR. So one of the things that we've been doing is thinking about our role in this, and we've come up with a similar model to provide the electronic medical record to non-Cleveland Clinic physicians. But it provides more than just the requirements for EMR. It provides the interoperability so that now those 4 physicians that are taking care of that cancer patient, they may not be in the same organization. Some may be in the Cleveland Clinic, some may be privately practicing docs. What's important is that the information that's required to make the right decision gets to that physician in a timely fashion. So our role is really to be part of the process to get physicians to see that the way to make that happen is through the adoption of this technology, and you can get much more than meaningful use out of it.
Our role as a technology company is actually to remove technology as the barrier for adoption. We want to make it easy. We want to make it secure. So we have mobile clinical computing. You can ship a dumb box to someone's office where there's nothing on it, so there's no patient data that's resident on it. They just plug it into the wall, and all the stuff's held in the cloud. They get their informatics and other issues there. The bigger challenge we have is helping people through changing their workflows, re-engineering their processes. Going through the transformation where what we don't want is for practices to just digitize an existing process because they'll just become better at making the same mistakes they've made all along. What can they do to actually adopt meaningful use and change how they practice medicine to be higher quality, safer, and greater value?
Walgreens is an open network. We partner with almost every healthcare system, every physician's group. Our goal is to make sure that there's interoperability. And so we're looking at clouds and the way we do that and making sure that our EMR system allows us to be able to send doctors to patients, physicians, and to them wherever they are. Very similar to the way Martin's building that out. We're fortunate at Walgreens. A lot of companies have many legacy systems that they're working in. We are piloting systems today, taking into account the regulations that have come out from some of the HIT regulation and partnering with a number of the companies going forward.
Okay, we have time for one more quick question.
I wanted the panel to speculate on this whole Facebook phenomena because a lot of the things we're talking about, privacy, connectivity, et cetera, are going to be radically altered by the emergence of this. So if you could speak on that.
Sure. I mean, one of the aspects is, now, when you look at social media, the norms for different generations involved in social media are quite different. You know, I'm on Facebook, I'm on Twitter, I even wrote a book, which includes aspects of social media in there. Reengineering Healthcare by Harry Greenspun and Jim Champy, available on Amazon and for Kindle. I think one of the issues is that the largest embracers of the sort of open and transparency about their personal lives are a population which generally does not have a lot of health issues. And what we need to see is how, as this group of people that is so free with sharing information suddenly starts getting health information mixed up in that, how open will they really be? But more importantly, you know, forgetting the downside, the upside of that is what is the benefit of people being able to share this information? One of the things I talk about in my book is actually group visits with providers and a number of different patients where they can share information with each other. It's sort of it's a social aspect to a medical visit. How can we, you know, take what's best about these aspects in social media and other sort of situations to improve the way we deliver healthcare?
So, you know, I think this is a new tool, and it's diffusing into our society, and I believe it will go right through the society, and it'll be used appropriately. So one of the things we're thinking about it, it's still early. I wouldn't rush there yet to use it, but I'm imagining the time when that population that does have diabetes or hypertension is also a Facebook user. And from my perspective, this is an enormous opportunity for us to drive patient education and to do that in a way that people like to learn, which is not in a big classroom, but at home and in a group of people with like issues.
I'd like to take this opportunity to thank my panelists today, Dr. Migliori, Dr. Harris, and Dr. Greenspun, who will be signing autographs in the back.
Thank you, Cheryl.